Next, I invite Dr. Carabirelli to speak on classification of ocular trauma, what's new. And actually, in Asia Pacific, we have termed it as ophthalmic trauma instead of ocular because oculus means the bulb eye, the eyeball, and so we want that next, so that we have included Akshay Nair, who's the next speaker.
Good morning, everybody. Thank you, Dr. Natarajan, for including me in your instruction course. I will be talking about ophthalmic trauma, an update on classification and recent terminology. Devising a classification system in medical science is often a challenging task due to the complexity and variability of the human anatomy and physiology. To classify all cases of trauma, to add three categories is necessary: non mechanical injury, adnexal injury, and destructive globe injuries, which is not there in the current classification. So, that is the reason why a proposed new classification was designed, which is broader based and comprehensive to allow a wider range of classification of ocular injuries not covered by the current classification, as a fifth of mechanical injuries involves the ocular adnexa. So it's very important that that is also fitted into this classification. Now, the BETS classification satisfies all criteria for standard terminology by providing a clear definition for all injury types and placing each injury type within the framework of all of our comprehensive system. So, what is the best classification? BETS classification, it is a closed globe and open globe injury, where the closed globe comprises of contusion and lamellar laceration, and the open globe comprises of the rupture and laceration, where it is a penetrating, perforating, or an intraocular foreign body, which is the kind of uh, injury that is there. So in 1996, Kuhn et al. Defined various terms used in ocular trauma and made a classification of ocular trauma for mechanical eye injuries. In this conventional classification, mechanical eye injuries were classified into open and closed globe, as I showed you. Now, what were the subgroups? The eye wall was the sclera and the cornea. The closed globe was no full thickness injury. Open globe was full thickness injury. Contusion was no full thickness injury, generally a blunt injury. And a lamellar laceration was a partial thickness injury of the eye wall, generally a sharp injury. And in the open globe subgroups, a rupture is a full thickness injury of the eye wall by a blunt object. A laceration is a full thickness injury of the eye wall caused by a sharp object. Laceration subgroups are those of a penetrating injury where there is a single laceration of the eye wall, no exit wound. Intraocular foreign bodies, which with retained objects causing an entrance wound, and perforating injuries where two full thickness lacerations are there with an entrance and an exit injury. So this was the classification which was given. And in 2009, a new classification of ocular trauma was proposed, which was a general classification which comprised of local, associated, and cause of injury. Now, local was mechanical and non-mechanical. In the mechanical injuries, there were globe injuries, destructive globe injuries, and adnexal injuries, which involved the orbit, palpebral fissures, and the lacrimal and conjunctival areas. And in the non-mechanical injuries, there were the chemical injuries, thermal injuries, radiation, and electrical injuries. In the general classification, associated injuries were associated in and around the eye, that is a head injury, a facial injury, or multiple injuries of any kind. And the cause of injury again was industrial, sports related, road traffic accidents, assaults, agricultural, or something concerned with daily activities. So when we see this classification, there was a further classification of the mechanical global injury into a structural and a pathological. The structural was concerned with the coats of the eyeball and the areas of the eyeball, that is, the anterior segment and the posterior segment, where anything could be affected. And the pathological was again the three groups, that is, the closed globe injuries, which comprised of a contusion, lamellar, which was lamellar, or a laceration, an extraocular foreign body, an intramural foreign body, or a dislocation. An open globe was again a rupture, penetration, perforation in intraocular foreign body, and destructive globe injuries, which were evisceration. There was an enucleation in some, full thickness laceration with affecting one third globe circumference. Now, there were three zones of the eyeball which were listed. The zone 1 was involving up to the limbus, the corneal part. The zone 2 was a zone 5 millimeters from the limbus onto the sclera, and the remaining came in the zone 3. Now, the zone 3 was affecting, like anything of the posterior segment fell in that category. So, this is like the kinds of involvement that you get of different structures in the eye. And then there came a study by Dr. Shukla et al. We are sorry he's no more with us, but he had designed a classification which allowed for classification of 535 causes of ocular injury, whereas the current classification is only of about 364 causes. So, injuries which involved the adnexa, non-mechanical injuries, destructive eye injuries, could not be classified by the conventional classification. Therefore, 33% was missing, and that was what he further classified. The classifications were approximately the same that I have already listed before, and he came to the point, again, the types were the same, that open globe, closed globe, and destructive. And what was more prevalent in his series was in the anterior segment, he found that more commonly the cornea or the lens was involved. In the posterior segment, the retina was involved or the choroid was involved. In facial injuries were more common in the associated injuries, followed by multiple injuries. And what was missing in the old classification is the most common closed globe injury was that of a contusion, which followed by a lamellar laceration, and the most common open globe injury was that of a rupture. So this was, of course, whatever the thing was, you manage accordingly. The management was by accurate history, examination, CT scan, MRI scans, and this is again a list. Now, there is something called as an OTS score, which he had designed, where there was no classifications or investigations or treatment guidelines that are internationally standardized and practiced. And there are numerous controversies and variability of the practice standards. And we herewith review the existing literature related to the relevance and practice of the ocular trauma score to highlight validated and effective predictive models. Now, its application was to predict visual outcomes and also to help audit outcomes when the predictive outcomes are not achieved. So this was how the OTS score was done, where the vision was the most important part, which gave you points, raw points like 60, 70, PL had 70, 1 by 200, 19 by 200 was 80, 20 by 200 to 20 by 50 was 90, and greater than 20 by 40 was 100. And there were negative marks for globe rupture, which was minus 23, endophthalmitis, minus 17, and so on and so forth. So you could have a rough calculation of what to expect if a surgery was done in this patient and how much to prognosticate to a patient. There is another called as an abbreviated injury scale, which is anatomically based, consensus driven global severity scoring system that classifies each injury in every body region according to its relative severity. And it's a 6-point ordinal scale from minor to maximal, where the face and eyes are important components. So, despite all this, there were certain things which were totally missed out in children, where they turned amblyopic after probably traumatic cataract surgeries and strabismus, refractive errors, and ocular opacities. These were not grouped in any of the classifications. So they decided to have another mathematical model called pediatric OTS, or the POTS. Now, along with the POTS, the Drishti Netralaya of Dr. Mehul Shah, and they have proposed another classification called TOTS, which is the Toddler Infant OTS, which was recently designed for children less than 6 years with open globe injuries resulting from trauma. The visual acuity and its benefits for prognosis prediction for traumatic cataracts with associated surrounding injuries like hyphemas, iris injuries, retinal detachments, or vitreous hemorrhage greater than 48 hours delay in surgery and endophthalmitis. The trauma score calculation in the TOTS was visual acuity was equal to 2x in this age plus zone minus corresponding pathologies, and this give you the kind of grading to prognosticate in this classification. Thank you so much for your kind attention.
Thank you.